Good morning, everyone. It is Thursday, February 3rd. Welcome to the Morning Medical Update. Thank you so much for joining us here on Facebook and on YouTube. Cancer patients already have enough to deal with. Can you imagine adding COVID to that? Dr. Jensen, Vice Chancellor and Director of the University of Kansas Cancer Center, he is joining us to talk about the impact COVID is having on cancer patients and the latest research. Plus, the American Cancer Society says to prepare ourselves for a surge in the number of people diagnosed with cancer. Dr. Ronald Chen, he is the chair of radiation oncology. He is joining us to explain and update his research on whether cancer screenings are still way down like we saw at the beginning of the pandemic. So please make sure to get your questions sent in to us on YouTube, Facebook, and on the Medical News Network. There are links to those right there on your screen. But first, let's get to our COVID count. And Director of Infection Prevention and Control, Dr. Dana Hawkinson, some good changes from yesterday.
I think so. I think in keeping in line with national hospitalizations, and we've seen kind of a decrease in those when you're looking at things like New York Post or Washington Post or New York Times. We are seeing a decrease in our hospitalizations here, which we now have for a couple days in a row. We have 89 active infections with 26 in the ICU and 14 on the ventilator. We still have 95 in that recovery period, but a total of 184. But overall, I think that's good news that our active infections continue to decrease. I think that's good news for our state, our region, the community, and of course, this is now consistent also with what we are seeing nationally.
All right, that's some news we want to hear. Dr. Hawkinson, thank you for that. Any reporter questions on the line today? All right, I do have one from KCTV5, and I'd like to ask Dr. Jensen and Dr. Chen just to weigh in on this. Jackson is asking, we've been reporting that burnout of nurses across the United States has been high. It's been as high as 68%. So many folks are considering leaving their jobs. So I wanted to ask you what we're seeing here among your colleagues in your departments and at the University of Kansas Health System and the Cancer Center. Dr. Jensen, what are you seeing when it comes to staff fatigue and burnout?
Well, we have certainly recognized that this is a major issue for our nurses and our other staff. And I think that, the prolonged nature of this pandemic and, now that we're into it almost 2 years, the fact that many of the sickest patients that we're seeing with COVID are obviously ones which decided not to be vaccinated. And so, we're having nurses and our staff working extraordinarily hard with very high volumes of patients. And, in large part, it really wasn't necessary. If we had achieved the levels of vaccination in the population that we originally intended, we would not be seeing these massive surges in hospitalizations and deaths, and we would obviously still be seeing infections, but they just came out with a couple of great studies showing that it really significantly decreases your chance of death, your chance of being hospitalized if you're vaccinated and boosted.
Can't say it enough. Dr. Jensen, thank you for that. Dr. Chen, what's your take on the burnout?
Yeah, I definitely see that too. I think nurses are tired. I think physicians are tired. I think all healthcare workers are tired. I think they're tired because the pandemic has dragged on for 2 years. I think they're tired because there's a shortage of healthcare workers, including nurses. And so people are actually being asked to work even more and harder than they were before. And also some of the things we used to be able to do, which is to have little gatherings, little celebrations to boost morale. I think those things are harder now with the COVID pandemic. And so I think people are tired. What I would suggest is that people just be nice to nurses. Be nice to nurses and appreciate what they're doing, appreciate them for staying in the healthcare, for taking care of patients. Hopefully this will be over soon. We'll be better.
Thank you for that. All right. Well, for cancer patients, the Omicron surge simply is scary. While they may be vaccinated, their immune system is not as strong as someone who may be considered healthy. Researchers have spent the last 2 years exploring the impact COVID has on not just anyone's immune system, but those who are fighting cancer. Dr. Jensen and Dr. Chen, both here with us this morning. So glad to have you both. Dr. Jensen, I do want to start with you because we only have you a short while. I'm going to let you go at 8:30 so you can get to patients. The National Cancer Institute has been researching the impact COVID is having on those with cancer and their susceptibility. Can you explain what this study involves and where we stand today?
Sure. So you're referring to the NC CAPS study from the NCI, and we have been participating in this study for nearly 2 years now. And basically, it's a natural history study where we monitor and keep track of patients who have cancer that get COVID, and we want to understand the disease in cancer patients, because as you have mentioned, many of our treatments in cancer and many different types of cancer significantly compromise the immune system, which causes it to inadequately respond to the virus, to inadequately respond to vaccination. And so it leaves these patients extremely vulnerable to this virus.
If I can add to that.
Yes, please, Dr. Chen.
Yeah, I think not only is KU participating in the National Cancer Institute study, there's another actually very large study looking at the impact of COVID on cancer patients that's actually led by the American Society of Clinical Oncology. So ASCO also has a similar study where they're following patients across the country who have cancer and COVID and see how they do. And KU is also a part of the ASCO study as well. And in fact, that study recently had its first publication that we helped lead that showed that some of the patients with cancer and COVID are more likely to have mortality from COVID, die from COVID, including older patients and smokers. And I think these studies from the NCI and ASCO that KU participates in would really help us have a lot of insights.
Dr. Jensen, explain a little bit about the importance of doing research like this here at an NCI designated institution like ours. And are we participating, and can people sign up to be a part of these studies?
Yes, we are participating. Libby Wolf Birchfield, who is one of our medical oncologists, is one of the leads on this study. And it's incredibly important because we need to understand the impact that COVID has on our cancer patients. We need to understand the impact that our treatments have on the ability of our patients to respond appropriately to COVID. And so that's what this study and the ASCO study are all about. And obviously, we have approximately 7,000 new cancer patients a year, and they have signed up NCI designated cancer centers all across the country because we all have very high volumes of patients, and we can accrue quickly. And in fact, my understanding is they're getting close to closing accrual on this trial because they have been able to recruit the number of patients they need to be statistically valid with their studies.
Dr. Jensen, it's been 50 years since the National Cancer Act was signed into law, really solidifying our nation's commitment to cancer care, cancer research. Yesterday, President Biden announced what he is calling Moonshot 2.0. So this goal is to reduce the number of cancer deaths by 50% over the next 25 years. Here's what he had to say about this plan.
For example, to prevent cancer, scientists are exploring if the new mRNA vaccine technology that brought us safe and effective COVID-19 vaccines could also be used to stop cancer cells when they fail, when they first arrive. Get them then. To target the right treatments to the right patients.
50% reduction in cancer deaths, 25 years to make this happen. Dr. Jensen, I'll start with you. How do we get there?
Well, I think, there's a lot of potential to impact in a positive way our cancer mortality. And, some of the ways that you talked about are, really are going to depend upon the research going forward. Some of the things we can do right now will have a dramatic impact, like lowering the smoking rate. We still have somewhere between 15 and 20% of adults who smoke in the United States, and smoking still is the leading cause of cancer. We also have close to 40,000 cases of HPV or hepatitis or HPV virus associated cancers that are diagnosed each and every year that could be prevented with vaccination. And so we know a lot of things right now that could probably cut the cancer death rate and cancer incidence rate in half if we just applied what we know. I think what the Moonshot 2 hopes to do is develop even more ways to prevent cancer, like potentially developing mRNA vaccines against the more common mutations that we see in cancer, and to determine whether or not that can catch this disease in its very earliest stages.
Dr. Chen?
I think this is definitely achievable. In fact, in the last 30 years, cancer death rates have decreased by about a third. And so for us to decrease by 50% in the next 25 years is definitely achievable. Exactly like what Dr. Jensen said, some of those things we already know can reduce cancer death rates. Early detection, prevention, and it's really just getting people to do the screening and early detection and prevention, stopping smoking. If we're able to continue to help get the word out and get people to screen and stop smoking, we can already get partway there. And then to continue research on newer treatments, I think will help us get there too.
Dr. Jensen, there's a study out when we talk about COVID and cancer and just what role our own genes play in our susceptibility to that and our response to that. What have researchers found so far?
Well, I think there's those studies are still ongoing, and we don't really understand why some people, when they get COVID, it's basically a bad cold, and other people wind up in the ICU on a ventilator with severe pneumonia and symptoms that ultimately lead to their death. And why one person reacts one way to this virus and another person, just kind of brushes it off, is a mystery. Now, some of the things that initially came out were maybe blood type has something to do with it. That really hasn't quite panned out. But there's certainly, it's true that comorbidities play a huge role in the severity of this illness, and particularly ones that impact the vascular system, and things like diabetes, hypertension, cardiovascular disease. All of those play a big role.
Dr. Jensen, the research that we do on cancer, is that helping forge a path towards helping to find other answer some other questions when it comes to like diabetes or heart disease? How do they work together?
Yeah, there's almost no question that really the technology behind the vaccines, much of that was developed by cancer researchers who were studying viruses and looking at ways to manipulate and leverage our ability to change gene expression. And so those technologies really all came together in the production of the vaccines, and things like our ability to deliver drugs specifically to cancer cells in lipid droplets. All of that research, or most of that research, was as a result of cancer researchers trying to understand how they could bring new cancer drugs and specifically attack cancer cells. So we owe a lot to kind of fundamental research, both in cancer and in vaccines and immunology, to our ability to develop these vaccines so quickly and to have such a great result and efficacy.
During this entire pandemic, screenings have been a major issue. Just take a look at your screen. I want to just show some numbers. The American Cancer Society predicts 2 million people nationwide will be diagnosed with cancer this year. That is up 1 million from 2021. A part of that stems from the fact that so many people simply waited so long to get screened. They were concerned of safety, they put it off due to the pandemic. Dr. Chen, you led the nation in the research on massive negative impacts that COVID can have on cancer screenings. We've talked to you about this over the last couple of years. You had this published back in May. Are you continuing to follow that, and what trends are you seeing?
Yeah, and just to catch up everybody, we led research here that looked at data from across the U.S. And the finding from this research is that we estimate there were more than 9 million cancer screenings missed in 2020, which is the first year of the pandemic. More than 9 million screenings missed. I think that's a very strong message. It tells us that we are behind, tells us that we need to catch up. Otherwise, if we miss screenings and delay it, there's going to be more later stage disease caught in the future, and therefore going to be higher cancer death rates in the future. It's really incredible to see that this research has really impacted policy. President Biden's speech yesterday actually mentioned this statistic that we provided, as well as speeches from the National Cancer Institute director previously. So people are aware of the statistic, and people are aware of the importance to catch up on the missed screening. There's more recent data that showed what we hoped is that when we had 9 million missed screenings in 2020, in 2021, we would catch up to higher rates than normal to catch up on the 9 million missed. And the more recent data showed that actually in 2021, we're actually still down about 5 to 10% compared to pre-pandemic. So there's still a lot of work to do.
Can you pinpoint what screenings have been missed the most?
Most of the studies have looked at the major cancer screenings, and so what we know is that the biggest ones we do are breast cancer mammography, prostate cancer PSA test, colorectal cancer screening, lung cancer screening, and also cervical cancer screening. Those are probably the major ones that we do, and that's what the studies have focused on.
And correct me if I'm wrong, everything you just mentioned, getting those screenings can prolong people's life. It allows people to get it taken care of and get it treated properly.
Absolutely. I mean, what I talked about a few minutes ago is that there has been major decreases in cancer death rates in the last 30 years. And the American Cancer Society attributes a lot of that progress to cancer screening. In fact, PSA test for prostate cancer screening was only invented in the 1990s and started to be used. And so that's a huge part of why prostate cancer death rates have dropped over the last 30 years. Now, one of the things that we've also seen is that starting in 2012, unfortunately, there was a guideline in 2012 that came out that said that we should stop prostate cancer screening. And so after 2012, prostate cancer screening across the U.S. actually dropped sharply. And unfortunately, along with that decreased screening in prostate cancer, we also saw that the progress in the death rates going down stopped. And so there's really a direct correlation between early detection screening and continuing to improve the cure rates and drop the death rates from cancer.
I'm glad you brought that up. Have there been any changes that people should know about regarding screenings? That just for folks who are listening, this might be a big wake-up call, and they might run out and get their screening in check. So just kind of educate us on what we need to know. Yeah.
So one of the major changes was in 2012 when the U.S. Preventive Services Task Force recommended no prostate cancer screening. Very unfortunate. The good thing is that in 2018, they reversed that recommendation. So now it's okay again. And people are hopefully getting that message and going back to their primary care doctors and getting prostate cancer screening. The other thing I think is really important to emphasize is that lung cancer screening also saves lives, especially for people who have a strong smoking history. And lung cancer is a very aggressive cancer. You do want to catch it as early as possible to be able to have a chance for cure. One of the things is that lung cancer screening really is not very widely used in the country. And so really people who have a strong smoking history should be seeking out lung cancer screening.
All right, what do you want people to know about coming back? It's safe. Have we gotten past that? We saw that in the beginning of the pandemic, people kind of waiting to get their screenings, but are we seeing people come back? What do you want folks to know?
It is absolutely safe, and I think all of us continue to provide the message that it is safe to go into healthcare facilities. We know how to handle COVID. We know how to keep patients safe. It is absolutely important for patients to go back to their screening tests. I think one of the issues that we haven't completely caught up on screening is that I think some people just fell out of the routine of doing their annual screening. And so people were doing it once a year, their PSA tests or mammograms or whatever, but once they stopped during the COVID pandemic for a year or two, maybe they're out of the habit of doing that. It's really important to pick that back up. It is safe to go to healthcare facilities. It's safe to call your primary care doctor and schedule those tests.
All right, we're going to get to community questions here in just a moment, but I just want you to know, Dr. Chen, something I know you love, talking about the Proton Therapy Center. So we're going to talk about that. The final countdown is on, what, we're 100 days?
We're less than 100 days.
Okay, so very exciting. We have watched this center be built from the ground up and actually the ground in, because we were lowering things into the center. It was so cool. So coming up, I'm going to show you some great video. Here's a little sneak peek. I don't know if we're supposed to show this, but we're going to show it anyway because it's so cool. I'm kind of a sucker for a good before and after. So we'll get to that here in just a moment. But first, let's get to some community questions because we've got some. And Dr. Jensen, I'm going to give the first one to you because we just got you a few more moments. But Isaac is asking about the idea of finding a cure for cancer. He says, I know that cancer is not just one condition, but a whole set of them. But just wondering if the idea of a cure for cancer is actually a possibility.
Well, I think as this reporter's already pointed out, cancer has many different diseases, and in large part, we're going to need to find a cure for each one of those diseases. So that's what makes it, so hard in terms of making progress against this disease. We can develop a fantastic new treatment, say for breast cancer, and it will have absolutely no impact on any other type of cancer. And vice versa. Say we have a great new leukemia treatment, but it's not able to have any impact on breast cancer. And unfortunately, we're dealing with a great deal of complexity when it comes to cancer. We're finding out that it's not just a few dozen diseases. It's probably hundreds of different diseases. And if you do genetic sequencing of every single tumor, there are going to be differences in every single cancer patient. Now, we think that most of those differences don't matter, but we're really trying to understand how we can personalize our care for each and every patient and develop personalized treatments. That's really what CAR T therapy and things like that are designed to do, is to identify a critically important change in the cancer cells that we can exploit that's different from the normal cells, and then use that as the basis for our treatment. And unfortunately, we rarely get to use just a single drug against cancer that is 100% effective, because cancer has a way of adapting and really learning how to get around the treatment that we use. And so in many cases, we have to develop not just one approach, but a number of different approaches to be able to, fully cure our patients. But I'm certainly very optimistic that we're going to make a lot of progress against this disease. I think, what a lot of people don't realize is that at the National Cancer Institute, less than 10% of the grants that agency gets are funded. And, frankly, that pay line needs to be increased so that we can fund more great ideas to try to battle this disease. And I think there's this country has the resources to be able to do that. And I think with the announcement yesterday, I'm certainly hoping that more resources will be applied to this problem.
Yeah, finding a cure for cancer. I would imagine that's what gets you and Dr. Chen up every day in the morning, coming here and serving our patients. Dr. Chen, you were going to say something?
Yeah, I just want to add to what Dr. Jensen said. I think another way, one way to also add to the answer to this question is that if every cancer is diagnosed at stage 1, we can cure almost everybody. And so if we diagnose every prostate cancer, breast cancer, lung cancer at stage 1, we can cure almost everybody. That's why screening is so important. I think a lot of the trouble we have is when cancer becomes later stage or when it's metastasized, and that's very difficult to treat or cure, and that's where the advances will help in the future. But if we do screening and catch every cancer at stage 1, we can cut the death rates by a lot right now.
Dr. Jensen, I promised I'd have you out of here by 8:30. So quick final thoughts, though, from you before we let you go.
Well, I think that, COVID has really exposed a lot of issues with our healthcare systems. One thing that we didn't get to talk about is that there's not a huge amount of slack in our healthcare system. So when we have things like, pandemics, or say, people suddenly decide to, get their screening for cancer center for cancer that's been delayed, there's not a lot of excess capacity in the system, and so it really strains our facilities, our personnel, and our resources. And so I think we really have or we need to think carefully about what we're doing as a society to make sure that we're able to handle these surges and plan for the next pandemic. We should be thinking about what we're doing, what we're going to be doing for the next pandemic right now, instead of waiting until it's comes upon us.
Dr. Roy Jensen, always glad to have you. Thank you so much for all the work you're doing, and your team as well. Have a wonderful day. We'll see you soon.
All right. Thank you. Bye-bye.
Thank you. All right. Dr. Chen, it's you and me. We got a lot of screening questions, so let's get to those. Joellen is curious, what is involved with lung cancer screenings for heavy smokers?
Yeah. So first, the most important thing to know is that most of the time screening is started by the primary care provider. And really screening discussions to happen when you see your primary care provider for your annual visit. And that is for lung cancer screening, but also is for mammography, PSA, colorectal cancer screening, etc. For heavy smokers, lung cancer screening usually involves a CT scan. And a CT scan can really look at your lung. And the idea is hopefully if there's a nodule in there, they can catch it as small as possible to then be able to treat that and cure that with a high percentage.
So Barry says that her PCP has never mentioned screenings to her. So what are the guidelines, and should she be asking certain questions when she goes in?
Yeah, I do think that, I think a lot of times in healthcare, not only should the physician and the provider provide the advice and direction, but patients should be asking questions too. Patients should really need to advocate for themselves. And cancer screening is a really important question to ask every year. For many cancer screenings, the age starts at about age 50. For mammography, for most of the prostate cancer screening, colon cancer screening, I think, starts at age 45. So about 45, 50, people should be asking their primary care doctors whether screening is right for them.
Of course, unless you have a family history, then you have that conversation much sooner.
That's right.
All right, Pat wants to know, if a person has COPD, how often should they be screened for lung cancer?
Well, so I think the initial screening is the most important. So they should have, again, there are very specific criteria on who should have lung cancer screening with a smoking history, how many years. Talk to your primary care doctor about it, but I think the initial screening is the most important. The initial screening to make sure that you don't have a lung nodule in there that's hidden, that's the most important. And after the initial test, then you can talk about whether the frequency of subsequent tests.
Shirley wants to know, my doctors seem to have different views on pelvic exams and pap smears for women over 70. What is your recommendation?
I think I think it is important to talk about when screening should stop and when screening stops being helpful to an individual. I think a lot of times, just on a very rough level, cancer screening usually stops when we expect people to have maybe a less than 10-year life expectancy. Because if we catch a cancer early, and oftentimes early cancers take a while to grow and cause the trouble, a lot of times I think for people who have a less than 10-year life expectancy, catching that cancer may not actually help a patient live longer and actually may be harmful because of the extra procedures and treatments that you may not need to make you live longer. So I think a lot of times patients and their providers need to have a conversation as they get older, estimate their life expectancy and estimate whether continuing to screen is helpful.
So not all screenings are created equal. They're not all lifelong. Good
That's
to
right.
know. Deb wants to know, and Dr. Jensen had mentioned this, Dr. Chen, but are you excited about the report of the gene therapy that was used on leukemia patients? What is that?
So I don't know the exact therapy that this person is asking about. I do think that there's a lot of excitement about gene therapy. There's a lot of excitement about immunotherapy, using the body's immune system to attack various cancers, including leukemia. There's really been a lot of research and progress in that direction, which has really made a huge impact on reducing the death rates from cancer. One of the things that Dr. Jensen talked about is the mRNA technology that could be applied to this type of therapy in the future. It's still relatively early and not yet ready for use, but other types of immunotherapy are already in use in cancer. CAR T therapy, for example, is something that's really, KU has led some of the clinical trials in the country, and it's really made a huge impact. There's other types of immunotherapy that are being used and being developed.
Dr. Hawkinson, jump in.
Yeah, and Dr. Chen, I think that's so apropos that you mentioned the CAR T, because it was a CAR T. Just information has come out within, under the last 24 hours. So, and just as you said, I was going to say, Dr. McGurk is just one of the biggest proponents, and I'm glad that you said we are one of the leaders here around CAR T. So it was with the CAR T therapy.
All right. I have a question about, hold on, let me find this one. Christy wants to know, what are the reasons why that younger women are getting breast cancer? She's 35.
Why younger women are getting breast cancer? I do think that, of course, with every cancer, there's a spectrum of ages when people are diagnosed. Breast cancer, I think, is still more commonly diagnosed in older women, and that's why screening usually starts at age 50 and above. But younger women can get breast cancer and other cancers too. Sometimes it's because of a strong family history, and maybe there's a genetic connection there. And so some younger women are diagnosed because of that. It's unlikely to be due to any environmental factors, I would say. It's probably related to either family history or genetic factors.
Don has a question, so I'm just going to throw it out there and you guys can tag team this one. Is there any research differentiating people with different types of autoimmune conditions? He is on Remicade infusions for Crohn's disease, but fully vaxxed plus 2 booster shots. Mm-hmm. Any insight on that?
I mean, is this in regard to immunity or
It's
risk
just any
of severe
research,
disease?
Yeah, just differentiating different types of autoimmune conditions. Any research?
Yeah, I think more important than the autoimmune conditions per se would be the type of immunosuppressive drug that you're on. If you're looking at immunity, either your ability to fight the virus or your ability to mount an immune response to that vaccine. So certainly Remicade could be an important player in there. The recommendation, we would still call you immunosuppressed, so the recommendation would be 3 doses for that primary series. And I believe that 3rd dose is going to come at least 2 months after that 2nd dose. And then, of course, the booster would be actually your 4th dose, which should be 5 or 6 months, I believe, from that 3rd dose. Definitely have a conversation. We've heard a lot from Dr. Jensen, Dr. Chen about having conversations with your medical team, your medical providers. Have those conversations with them about, being up to date with that vaccination. So I think that's the important thing. And if there's further questions in there, just please clarify and we'll try to get those answered.
Bridget has 2 questions. How much protection does a cancer patient have who is fully vaccinated and boosted but is actively doing Doxil chemotherapy?
Yeah. That's a really good question. I think I think part of this has to do with how immunocompromised somebody is and the protection from the vaccine. Some of the recent guidance have shown that for immunocompromised individuals, really there should be probably 3 baseline doses plus a 4th shot, which would be considered the booster. And immunocompromised patients may be people who are actively undergoing chemotherapy. And so for those individuals who are immunocompromised, maybe actively undergoing chemotherapy or getting steroids or other immunosuppressive drugs, sometimes a 4th dose may be necessary.
Help Vicki understand what you said earlier. If pelvic exams are stopped at 65 or 70, how can ovarian cancer be detected?
Well, one of the ovarian cancer is still a very tough cancer. Unfortunately, there's not a good screening test for ovarian cancer just yet. And unfortunately, we only have good screening tests for some of the cancers, but in other cancers, ovarian cancer is one of them that people are still trying to work on.
Bridget had one other question. Is it also still recommended for cancer patients to do a second booster 6 months after their first booster?
Yeah, so this is what I was just talking about, sort of a 4th shot. Really, I think and this is again for immunocompromised people who have moderate to severe immunosuppression. So for cancer patients actively undergoing therapy that may be compromising their immune system, a 4th shot may be necessary.
All right, let me ask this question, and you may have talked about it, but ovarian cancer is often referred to as the silent killer, as it is not detected until late stages. What screening is available or possibly in the works to detect the cancer earlier?
Yeah, there's not a proven screening test for ovarian cancer just yet, and I think that is a major problem. There are many studies going on to try to improve screening for ovarian cancer and other cancers where we don't have a screening test for. Some of the things that I think are really promising are these blood-based tests that can sort of look at maybe either tumor cells floating around the blood or even DNA from tumor cells floating around the blood. And so possibly in the future, we could do a blood test that can detect many kinds of cancers at an early stage. I think there's a lot of work in that area, and I'm hopeful that will lead to some results in the future.
All right, Isaac says he still remembers the episode that we did where we were placing tell me the name of the big machine that goes down into
the cyclotron.
The cyclotron. Yeah. Okay, that was it. So he remembers when we were showing that. We're going to get to that here in just a little bit. But he has a question. Compared to radiation or chemo, does proton therapy in its precise target of the cancer have less of an effect on immune functionality?
I think it can. I think so. The difference between proton therapy and other forms of radiation, again, proton therapy is one form of radiation, but the difference between protons and other forms of radiation is that it hits less of the normal tissue in the body and hits the tumor more compared to other types of radiation. And so in the sense that if it hits less of the bone marrow, then it could have less of an impact on the immune system than regular radiation.
Dr. Hawkinson, Don wrote in trying to clarify what we were talking about with that immunocompromised question. Just wondering about immunocompromised people's susceptibility to be hospitalized or die from COVID, as far as differentiating those different types of diseases.
I think that is very important to be able to differentiate those. I think just understanding and knowing what we know about people with who are immunocompetent. I think there are different types of immune suppression, and whether that's immunosuppression directed against all of your immune cells. Certainly people undergoing high-dose chemotherapy will have that. Is it immunosuppression directed at B cells, which create the antibodies, or is it immunosuppression directed against T cells, which help kill those virus-infected cells and really provide that great protection against hospitalization, severe disease, and death? I think that's a good question to ask, and hopefully, when you are on those immunosuppressive drugs, your primary care team or the care team that's managing those can help answer those questions. But I think we do just broadly categorize immunosuppression because we know people who are on all types of those immunosuppression are probably more at risk of going to the hospital, having severe disease and death. But we also know that getting the vaccinations, getting the primary doses, and then getting that booster is going to help reduce your risk overall as well.
Last question is from Donna this morning. Should a person on CellCept get their second booster 2 months after the vaccine, or get their booster 2 months after
Yeah, I would say, if you're on CellCep, again, I think it's going to be a broad category. We know that these vaccines are safe. So getting that extra dose is not going to harm you. There's no there's no data signals about safety for that. And if you are on these immunosuppressive drugs, and again, as a provider, most of my patients, again, HIV, they're well controlled. But if you are seeing patients with autoimmune diseases or solid organ transplant or autoimmune diseases, and you know that they are on immunosuppressive drugs, really any type, I think you should take that definition pretty broadly and be able to dose them with that fourth dose after really, the first two. And then if you're immune suppressed, really it's that 3-dose series rather than 2. So that fourth dose would really be the booster, whereas the first 3 doses are really that primary series. So I think it would behoove you, and I think it would be beneficial to go ahead and get that fourth dose after 5 to 6 months from your third.
All right, actually, Jennifer's going to get the last question. Is a colonoscopy a screening for colon cancer? Is that the screening, Dr. Chen?
Colonoscopy is a proven way to screen for colon cancer. Absolutely right. I think during the pandemic, some people have not wanted to get a colonoscopy out of fear. There are alternatives. There's actually a FIT test where it's basically a stool sample that's an alternative colonoscopy. But colonoscopy has been around for a long time. It's proven to be effective for colon cancer screening.
Dr. Chen, nobody wants to get a colonoscopy, let's face it, but very effective, good to know. Okay, so I want to get to our final thoughts, but first I promised a sneak peek inside the Proton Therapy Center. It is very cool, kind of a before and after. We just want to talk with you, Dr. Chen, because I know this is your big project and we're just about 100 days out from serving our first patients. Just remind people what proton therapy is.
Proton therapy is a type of radiation that's used to cure a lot of different kinds of cancers. And again, the difference is that this type of radiation, proton therapy, reduces the damage to normal tissue and focuses more on the tumor. It's used for a lot of different kinds of cancers, including pediatric cancer, kids with cancer. We're really excited to have this as the only one really in this entire region. So patients don't have to go out of state to other states to seek this therapy.
Well, that was my next question, just the impact of having it right here smack dab in the middle of Kansas City so people can come, because sometimes they will get this treatment and have to be gone away from their families, going through cancer treatment alone, missing work, and now they get to do it right here.
Absolutely. We will be only the 38th proton center in the entire country, which means multiple states don't have a single one. When we have this here in early May, first week of May is when we'll be treating patients. We will offer this to our patients. And proton therapy often is a daily treatment for maybe 6 weeks. And so for people to go to out of state to spend 6 weeks and quit work or quit their school or whatever to seek the therapy really is impossible for most patients. So we'll be able to provide that service right here.
Yes, we look forward to welcoming those people from all over the states and caring for you right here in our backyard. So we're excited about that. Final thoughts from you, Dr. Chen?
Be nice to your nurses. Be nice to your healthcare workers. I think, and I mean that seriously, I think people are really stressed. Sometimes in healthcare right now, there may be delays. People may be frustrated, but be nice to your healthcare workers.
Give grace. Get your screenings.
Yeah.
Dr. Hawkinson, what else can you add?
I think it's so important. Get your screenings. We do hear, and we have heard since the beginning of the pandemic, people want to do their own research. I think that's great, but just make sure that those research outlets are verifiable. They are accurate. One good place to go to just kind of look up and then maybe have conversations with your primary doctor or your OB-GYN, if you're seeing an OB-GYN, would be the U.S. Preventive Services Task Force.org or USPSTF. You can look that up on Google. They have recommendations for screening, so you can go and just get a head start and maybe start to have those conversations with your physician so that you can get those cancer screenings done. That is extremely important. However, I don't think that we are going to here on the MMU be doing any rehashing of Katie Couric's broadcast of her colonoscopy.
That will not be happening.
It'll all be private, but again, I think, understand those accurate sites that you can go to, and the U.S. Preventive Services Task Force website is very good for at least identifying what kind of screening you would need, and then absolutely have those conversations with your physicians.
Very helpful. Thanks for sharing that, Dr. Hawkinson. We'll see you tomorrow, and thank you so much for being with us today. Do not forget, you can catch our shows anytime by logging on to our Facebook page or our YouTube channel. Coming up tomorrow, people may be over the initial symptoms of COVID, but many are still facing long-haul symptoms. We're going to take a look at how those patients are doing. We'll also find out from our pharmacy leader how we are coping with drug and supply shortages. And as we leave you today, we asked our team to put together a very special video of the new Proton Therapy Center. It is so beautiful, and we just wanted to show that to you, give you this special behind-the-scenes look. So enjoy this, and we will see you tomorrow at 8 o'clock.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.